Okay, good morning, everyone. I just wanted to get you to get your last coffee. We're about to get going. Thank you, Sabrina, for that assistance. So you've been to many weddings. It's a real pleasure to be able to introduce this morning because yesterday was a phenomenal day, but I'm going to tell you right now that there's going to be no shortcomings here. This panel, spoiler alert, they're not very wishy-washy. They've already decided what they're going to do and how they're going to engage you. And so they've decided what they're going to do is they're going to do 10 minutes of each of giving you their take on where we should be going in the future. Then they're going to have a little bit of a brawl up here at the front. You know, they're going to sort of challenge each other. And then they're going to engage you, and they're expecting you to get up to the mics and get part and parcel of the whole process. So get ready, get your pens ready for the kinds of things that you want to write down, that you want to challenge them with. Now we're going to start, I don't think any of these people need introductions, but Dr. Ian Morrison is going to start, followed by Dr. Stephen Lewis, followed by, and wrapping up the end, Dr. Michael Rachlis, who I think you saw many times yesterday. So it's a pleasure to have them here, and thank you very much. And Dr. Morrison, over to you.
Thank you. Thanks, Robin. Good morning. So, what great joy to be here. That was fun last night, and I think it was a misnomer, Bob, a roast. It lacked the sear and the sustained high temperature. It was more like a braise, warm and delightful without being too sweet. So hopefully that was fun. I'll just remind you, I was a student at Bob's in the 80s, and it actually was lovely because the punctuation marks he pointed to in his career, I was a student when he was writing Strained Mercy, and then when I was at Institute for the Future as president, Morris was on sabbatical and hosted the Merry Pranksters from the Canadian Institute of Advanced Research, many of whom are here, so it was great fun to catch up with all of you. So our topic is innovation. My question is, can Americans solve healthcare through innovation, and are there lessons for Canada? The short answer is probably not, and not much. Thanks for my time. It's been wonderful to be with you. But as I said yesterday, my only qualification really is I'm a Scottish-Canadian Californian, which gives me a unique perspective on healthcare and all things to do with healthcare, including death and dying, because the Scots see death as imminent, Canadians see death as inevitable, and Californians see death as optional. I mean, we don't do it. So I have to give my PhD back unless I do a couple of minutes in international comparisons. I'll give you a little checklist of innovations in the U.S. and be impertinent enough to say what might be useful for you quickly. And we can, Stephen said he's going to give me the hook after 10 minutes, whether we get through this or not. So one of the things I did since I've lived in the States for 30 years, a relationship with Berkeley, and I've taught as guest faculty at the Global Health Leadership Forum they run, Steve Chartel does. And my little contribution as guest lecturer is an equation that I think I stole from Bob. And it's really the question of innovation for what? And I believe most health systems are struggling with the same thing, and it's innovation for value, and crudely value is access plus quality, not fancy buildings quality, health outcomes, health status improvement, health gain, and some kind of measure of security of benefits, or you guys up here might talk about equity over cost. And look, I've lived in 3 countries. Every health system in the world is an ugly compromise in this equation. They all suck in their own unique way, right? There is no perfect health system, but I torture Americans, to use the phrase from last night, with the fact that the Americans have the worst value in the world, right? Because they spend so much, right? We all know these data. And I love to break it out this way for Americans and point out that they're the largest government-run health system in the world per capita. They just have another 7 percentage points of GNP on top. Now, those of you with good eyesight will point to the fact that Norway actually spends more. But Norway's a very odd place. It's a cross between Sweden and Saudi Arabia. You know, it's like it's socialist with oil, basically. And the great John Frank pointed out yesterday that that's what the Scots had. They had this flirtation with independence. The idea was to get the North Sea oil money, give free whiskey to everybody, and it would be unbelievable. It'd be a complete bloody disaster if it happened with $30 a gallon oil. And the only people that voted for it was the Glasgow housing estates he was talking about yesterday. All right, so we spend more. The other thing that really is embarrassing for Americans is they're dead last in the national comparative statistics. The Commonwealth Fund, which was really originated by my colleagues Humphrey Taylor and Bob Blandon, comparative research using surveys, and America's last, right? But remember who's second last? Canada, right? You know, I mean, I have clients in Oklahoma and Mississippi, and my clients in Oklahoma say, thank God for Mississippi, so we're not last. And that's kind of what Canada is to the U.S. You know, it's good that it exists, otherwise you suck, right? And Bob always taught me that Canadians are different from Americans. They describe themselves as unarmed Americans with health insurance, you know. So turning to innovation. Now, we're doing a lot in the U.S. Most of it is rubbish and won't work. We've obviously expanded coverage, and you know, Ted could have designed a health system in half an hour if they'd given him a chance, but we did this crazy Obamacare thing. And I'm a big Obama fan. I mean, I became an American citizen to give him money and vote for him. My wife's Canadian. We both did. And you know, it's the biggest drop in the uninsured since LBJ. You know, we can say what we like. It's not the best way to do it, but we covered a lot of people. And every state in the union has seen a reduction in the uninsured, with the exception of Wyoming. Nobody lives in Wyoming, so who cares? You know, so we're doing a lot there. We're also frantically doing a lot on payment reform, and it's massive. And I think that's a big part. And 2015 was the tipping point for this. And we can get in discussion about some of the minutiae of it if you care. I wouldn't care too much, but a lot is being placed on this notion of payment reform. The third thing that is going on is a massive shift in the conversation strategically. And the one, I spend most of my time in the private sector working with leadership groups and boards of organizations, you know, like Kaiser or the American Hospital Association. And there is a real substantive conversation amongst leaders going on, moving from volume to value, as we say in the US. And that's forcing people to consider population health. The other big trend is consolidation and integration. A lot of scale, a lot of partnership, big institutions, 10, 20, $30 billion revenue enterprises being built through massive regional consolidation. And there is a mega shift towards the ambulatory environment, including retail. And there was some conversation of this yesterday in the Canadian context. A survey just came out this morning. 26% of Americans have used a retail clinic. 79% of those said they did a good or better job than the last visit to their doctor. So the rise of retail and alternate sites of care is significant. And we've also in the US made massive investments in information infrastructure, what I call meaningless use. But we do have achieved really ubiquity of electronic health records. The big next step is connectivity, particularly to consumers. And one of the things that we're seeing is a significant amount of innovation targeted at improving the consumer experience, partly because they're paying a lot out of pocket. They never read Bob's lecture on user fees, and you know, about half of employed Americans have a deductible of $1,000 or more. 25% of American workers have a deductible of $2,000 or more. So a lot of the first part of expenditure is retail, and that's what we're seeing. And it's one of the reasons why we're asking of the provider system to be more responsive. I mean, this is just from the Commonwealth Fund. America ranks dead last in after-hours care for primary care Canada, second to last amongst the countries measured. This is profoundly ironic. You can get a cheeseburger anywhere in America at 3 o'clock in the morning. You can't get in to see a primary care doctor at 6 o'clock at night. It's nuts. And that's why in my neighborhood, Stanford, Stanford's built on-site clinics at Qualcomm. I'll remind people that Qualcomm is in San Diego, not in Palo Alto. And Palo Alto Clinic, where I go, has this big van with 2 treatment rooms that goes to the parking lot of the companies listed on the right-hand side. And the doctors at Stanford go and see the Googleites. You know, and that's the dream. Google wants to keep people in the cubicles. They put pizza under the door, and the doctors come to them. I mean, that's the American economy. I'll skip this and come back in the interest of time. I just wanted to close with a couple of observations about population health. What we're seeing is the epiphany going on in America of people saying maybe we should be concerned about the whole patient. Maybe we should look like Kaiser and get in the insurance business. And they're doing the math. And it's why those of you who are population health specialists may get a lot of phone calls. What's happening in the U.S., we're seeing people do the math and saying 5% of patients account for 50% of costs, 1% account for 20%, and the bottom 50% of users use next to nothing, right? And I just checked with Nuru Roos that this is actually pretty similar in the Canadian context. So who are these 1%? Well, what you find in almost any commercial insurance pool, you'll find Hondas. I'm a Honda. I got thrown off of health insurance in the individual market in California before Obamacare. They told me I was a Honda in triplicate: hypertensive, obese, non-compliant, diabetic, alcoholic, right? None of which is true, but is all kind of directionally correct. So you find Hondas, you find behavioral health. 40% of people in that heavy user category have behavioral health issues. In the end-of-life care in Medicare populations, they will definitely be in the top 5% heavy users. And the punchline here that Bob taught us way early on is the solution set may look a lot more like social work and social justice interventions than medical care. And that epiphany is happening, I think, a lot in the United States, and that is to the good. And I'll reserve my comments later about what that might mean for Canada, but I just wanted to introduce those two contributions that Bob has been connected to, which I think are really profoundly important. And I personally am quite excited about the pace of innovation in the U.S. Finally, we're starting to do things in the delivery system that might actually make a difference. So let me pause there and cede time to my colleagues. Thanks.
Okey-doke. All right, good morning, everyone. I have slides, but I'm not going to share them with you. You're not worthy. No, I didn't have anything to say on the slide that would be that important. I should do it correct. I'm not Dr. Lewis. If you must refer to me by credentials, you can call me Master Lewis for the rest of the day. Okay, so I'm going to take a slightly different take, which is good on a panel. So it is that innovation, the people in this room probably have a remarkable consensus on what innovation needs to take place, as do 95% of Canadian healthcare reports and 90% of what's contained in them. They're pretty much identical. You know, primary care should be better value for money, more integrated, a shift away from the procedural to the cognitive parts of medicine because of the growing elderly population, and yada, and yada, and yada. So what I'm going to talk about is, if there is consensus in this room, how come there isn't consensus out there beyond this room, and why things don't change, and why, and I'm going to end with a bit of optimism, why maybe this time we might be a bit closer to making some significant changes. Well, the first reason why things don't change is because people don't want to. So when we say the system gets bad value for money, that is precisely the bad value for money that makes it very good value for money for the people receiving the money. So if you overpay me for my consulting services, never happened, I'm a beneficiary. Well, healthcare employs an awful lot of Canadians, and the typical income among many, though not all of the occupations, is very high. So getting bad value for money out of hundreds of thousands of people is actually a very rewarding experience for those people. And it's even indirectly rewarding for the people who live next to them, because the real estate value will rise in relation to their fancy house, et cetera, et cetera. So it's a very real phenomenon that this complex system has a lot of people who do very well by it. A second one is that actually the system works pretty well for the people who are politically important, which means the middle and upper middle class in this country. So I'm sorry, I think Danielle left. Oh, you're here, good. So we have this conversation about pharmacare, and I always say to Danielle, well, Danielle, the real reason we don't have pharmacare is because most Canadians don't think they need it, because they already have some semblance of it, especially if you're employed in a large organization, if you're a public servant, if you work at a university, if you work in a large unionized environment, you have pretty good drug coverage. And you may recognize, just like the Americans do about their system, that it's kind of stupid, but it's embedded, you're okay, it's not something you think about every day. So where is the groundswell in favor of it? Well, it's among people who care about justice and good value for money and so on, but that's diffused, and it's very difficult to achieve that sort of consensus. So it's path dependency in a sense. Whatever we have, however irrational, seems to serve a lot of people well enough so that they're not getting excited about it. A third one is that there is consensus and people really want to change, but it's too complicated. There are too many moving parts. I forget, maybe it was Ted yesterday who said alignment is a problem. To align all of the moving parts to get the change you want can be extraordinarily difficult. Cabinets are not all united. Departments are not all united. There is a chasm between the people delivering services and the people making the policy. To get all of them moving in the same direction in a coordinated fashion to get the outcome you want is pretty complicated, particularly in a democracy. And then the final reason, I would say, and Ian touched on this a little bit, people may want a lot of change, but it's a different kind of change. So, for example, people who want better value for money and a more efficient and effective healthcare system, like most people in this room, would argue for a whole lot of restructuring, reallocation of resources, greater accountability, emphasis on quality, etc. But the people who are interested in improving population health, with the big part of the triple aim, would say, as Ian just did, well, actually, that really doesn't have much to do with the healthcare system, and there is almost no restructuring, retooling, reinvention of the healthcare system that is going to do much about inequality in health status. And as we have seen from Europe, where they care about this more than we do, even after 20, 25 years of efforts to reduce population health inequalities, it's proven intractably difficult. So it's a very hard thing to do to unwire the inequality in health status that's built into societies. And where do you put your efforts? So my theorem, then, that I derive from all this is that Canada will not change unless all other options have been exhausted. And which doesn't mean, however, that I should qualify that by saying Canada won't change dramatically and visibly in the short term without exhausting all the other options. But it doesn't mean that change hasn't occurred on a grand scale and we've sort of not noticed. A great example is my friend Kim McGrail's work, in which I play a bit of a cameo role, about the change in primary care in British Columbia. You know, you have a province with I would argue, superabundance of doctors, especially compared to parts of the rest of the country, and primary care doctors in particular. But only a quarter of primary care doctors provide what anyone would consider a full-service practice where they serve most of their patients for most of their care needs in the primary care sector. So the response to superabundance has been to shrink primary care. It's not the only reason, and the other reason is that with a technology-intensive healthcare system, primary care has arguably lost its clinical nerve. That instead of doing a history and physical and observation and interaction with patients, we rely on technology because that is a cultural meme that has coursed through society. It's not just in medicine. We all think that if you can do something with technology, it's a lot better than if you do something simply by using your head. And that's made a profound difference to the practice of medicine. And so we have this problem that if you took a snapshot, cross-sectional, 1985, 2015, what did primary health care look like, or primary care look like? It would look vastly different. But we didn't notice the change because it was incremental, and here we are, and it's a big, big problem, at least so I would argue. Okay, so with all that, you'd think, well, I have no hope for change. In fact, I would say my natural inference from what I just said is that things are going to get worse, only it's going to get more expensive, and it's just a terrible, bloody mess. But I actually am optimistic on a couple of grounds. One is actually kind of democratic, and again, it's largely the people in this room of my aging demographic. It's not us, but we all have parents, and it's shocking. When you have a conversation with the people of a certain age, like me, we all have, if we're lucky, well, on some days we're not so lucky, we have parents. And the experience that our parents go through is eerily the same. It's preposterous. It is a ridiculous over-servicing. Too many drugs, not enough conversation. I spend a lot of my time fending off the medical system that wants to get hold of my 93-year-old mother. And it's always the same. Like it's inconvenient, it's inappropriate, it's not holistic. So that's starting to make us mad, but it's vicariously mad. but we will soon be there, and then we'll get really mad. And I think we will start demanding some significant changes in the way that primary care is organized. And I think actually the practitioners who start figuring that out will do very well in that new era. The second is that, and Jerry Hurley will, I hope, argue with me on this one, if he's still here, is that I actually believe that the surplus of doctors is creating a different circumstance, and that doctors are starting to figure it out. They are realizing that you cannot shoehorn vast numbers of new doctors into a fee-for-service system that not only requires them to be active, but requires them to generate others' activity, about $2.50 for every one that they get paid themselves, in a foreseeably tight fiscal environment. So I think they're seeing the math doesn't add up and that they're going to have to do something different. We have 13 natural experiments in the country because of the way the jurisdictions operate, and I think one or two of them might be interested in a different conversation. And we've seen some shots across the bow, probably not in an ideal way, but in Ontario, where the stakes are getting pretty hot. I guess why I am most optimistic is that I think there is a bit of a cultural shift going on at the early stages, and that is from a conventional narrative of scarcity to a growing recognition that we may have in many areas superabundance, hence the Choosing Wisely campaign, which has now identified over 100 procedures where doctors have said we use too much. It's obviously not a wildfire yet, but I think when that narrative starts to change more widely, we will have a different conversation. And just to wrap up, I'm saying that the conditions are there that may create a greater opportunity for change. I am not of the historical inevitability school, and I don't believe we have a perfect storm, but I do believe the outlook is rocky for the status quo, and I think we are seeing an increasing number of leaders on the ground in the system as well as politically who are prepared to accelerate change a little bit more quickly than we have seen before.
Thank you. I really enjoyed my panel. I wanted to go last, and that's because I can go through a lot of my slides now because they've already been covered. First of all, for those of you who are not from Canada and you think Vancouver is Canada, it's not. This was my backyard on Monday. Access, what I'm going to talk to you about is access to primary health care is crucial for patients and health system performance, as Stephen has said. We have terrible access, as Ian has said. We could have much better access, and I'm going to get into that a little bit. Why don't innovations spread faster, and how we could facilitate innovation with better politics, which I'm mainly going to leave for further discussion at the end. But delivering health services without adequate primary health care is like pulling your goalie in the first period. You're going to score lots of goals and you'll lose every game. Our hospital system, from what we know, apparently is as good or bad as most other countries. Our primary health care sucks big time. And it's not because the doctors aren't well trained or nurses, if they are in practices, aren't well trained. It's because, of course, that the processes that we use in our healthcare system are not just hundreds of years old. They probably go back 1,000 years, and it's just about time to revise them. So as Ian has shown, you know, the Commonwealth Fund reminds us every year that we're often the worst in access variables. So here we are, you know, longest wait times for family docs, longest wait times for specialists. In some, and we're the heaviest users of emergency rooms, except for Americans who don't have health insurance. And it's true that sometimes we beat the Americans, and it's like winning a high jump contest against midgets. The bar is really low. Sorry for the midgets. And doctors can and here we, again, isn't it great that we've got about a 35% increase over 3 years and doctors who can electronically exchange patient summaries? You know, well, it'd be great if we just showed those bars, but the others show that we're way behind. And this was in the Globe and Mail on Monday. I couldn't resist taking a picture of it. You know, plus a change, plus même chose. Sorry, Francois, for my accent. With current resources, Canadians could, of course, have immediate access to primary health care. Elective specialty input within 1 week, usually, I mean, really, if we did it right, within hours, we get the input that you need. And we could get elective surgery within 2 months. How many of you in this room have heard of the Alaska South Central Foundation? We're in BC. How many of you visited it? How many of you have gone through the economics, the financing? Okay. We'll talk later. I think I know more about SCF than anyone else in Canada, and I've gone to the point of upsetting them in asking them about their finances. So I'm pretty sure that, and for those of you who've seen them present, they're like typical Americans. You know, after a few minutes, you figure they're trying to sell you a used car. Ted, you know this too, that showbiz is essential for Americans and for Canadians. It just makes us feel like, you know, we got to hold on to our pockets. The Yankees are going to stick their hands in. And Scots, of course, would never say anything good about themselves. So unless they move, is that right, Ian? Yeah. So the South Central Foundation, for those of you who don't know, was created about 20 or 30 years ago with the devolution of responsibility for healthcare of some Alaska Natives to the U.S. Indian Health, from the U.S. Indian Health Service. 65,000, what they refer to as customer owners, 1,800 staff, a budget of about $250 million. And during the past decade, they've been recognized as one of the world's best health systems. And they're 90% as good as their press releases. So they're not as good as they say, but they're nearly there. And this is from a visit I made last year. All the teams, primary care teams, each family physician works in a team with a nurse case manager, a clinical support worker who's typically a U.S. Certified medical assistant, and a administrative support worker. Every team in their backstage area has their metrics from the previous month, and so everybody can see it. And I asked them, do you mind if I take pictures? Please take pictures. And they really were upset when I was there in April of last year because they implemented a new wrinkle to their electronic medical record, and they only had 33% of their appointments available that day at 9 in the morning. Their aim is 50%. If you phone at 1 o'clock in the afternoon, you will be seen for sure, and you will almost certainly, if you need it, see a behavioral health specialist the same day. And there's the backstage area, the 4 people in the clinical micro team, and in Canada, in fact, Rick Glazier's here. Rick, you've been fairly quiet, but I would say that most people I talk to in primary care, even people who are supposedly thought leaders, do not know the phrase clinical micro team. So, and you go to a place, whether it's one of the regional authority primary care centers. I remember 20 years ago talking to Jack Altman and Sharon Martin. They were putting these together in Vancouver, and I said, when you think about wonderful people, I should say, terrific people, well-meaning, and maybe they wanted to do what I was advising them about, but couldn't get it done. But they moved public health, mental health, and public health into the same building, hired some primary care docs, and then we just sort of stir it around and we get good performance. We don't. So or even in the community health centers, which I love that model, most of them, you say, do you work in teams? Oh yeah, we have a great team. We've got 81 people in this building. We're a great team. That's not the way the patients see it. And so the clinical micro team at SCF sees patients for 95% of their primary care visits. Incredible continuity, 1,200-person panels with high degrees of complexity. Hamilton Mental Health Program, Nick Cates' model you all have heard of, integrates the practice of 22 psychiatrists part-time with a bunch of family docs and other people, and after they implemented the program, the referrals to the outpatient clinic collapsed, and when they expanded the program, inpatient hospitalizations also went down. We've got some good models in some provinces for dealing with elective surgery, which involve central intake pooling of patients. With Saskatchewan has done really well and gives me some hope for the future, and using other providers like advanced practice physiotherapists so that you don't waste your time seeing an orthopedic surgeon unless you can get something out of that consultation. So why don't innovations spread faster? Just strewed on my office floor various documents over the past 45 years, including some really good ones at the bottom, the Hastings report on community health centers in 1972, and the Health Planning Task Force in Saskatchewan, one of many reports written by the redoubtable Dr. Mustard, and we missed our opportunity back then to change the way we delivered medical services, and so we continue to deliver them the way we have for hundreds of years. There are lots of other issues that we can talk about. There are other providers who are can be nasty at times, but I think the biggest issue is the lack of effective clinical governance. You do not get high-performing systems like in Alaska or at the Mayo Clinic or in Scotland without effective clinical governance and high-performing medical groups. So here's an example. Elliot Goldner's research, and I'll try to be fair in this because I know that some people have said he wasn't being fair, but a wonderful little survey. Any of you familiar with this study Elliot did in Vancouver? No, you got to take a look. Somebody is. You all need to know this. So of 230 Vancouver psychiatrists who see patients, what percentage say they could definitely see a referral in timely fashion? 3%. As near as we know, in Vancouver, Winnipeg, and Toronto, 1/3 of psychiatrists see fewer than 100 discrete patients a year, which means they're providing long-term psychotherapy to people like you and me. And actually, even though we've got problems, long-term psychotherapy doesn't really work for anybody. So where's the medical group? Where's the discipline saying you can't do that? You have to be available to see patients. So the rules we've got in our system, and again, nod to Colleen, I believe the first place to start is look at the formal decision-making system. Shout out to Jonathan. This is what I felt I learned from you 25 years ago. Start there. Start with what the laws and rules are. Don't go around the borders first. Start with, and all high-performing medical systems have high-performing medical groups, but effective clinical governance is impossible in Canada. Even the best systems with the best clinical governance, like Cancer Care Ontario, let's say, is often touted, doesn't hold a candle to these other systems. And in the community, you can see whoever you want, work the hours that you want. Nobody seems to care. Lodge a complaint if you've got a problem. Canadian doctors should do their work very differently, but it's almost impossible to pay them to do so. Provincial medical associations mainly control the allocation of Medicare dollars, and that's what really gets Ontario doctors upset when the provincial government starts mucking around in there. Now, just to remind us, the founders of Medicare, back in the old days, 40 years ago, those of us who were championing Medicare were also championing the second stage of Medicare. Tommy Douglas said it very well. Just providing public insurance for the old system is only the start, that we have to change the way we deliver services. So with that, I look forward to the conversation, and we'll get into some of what the political things that we need to get into. And I'm very pleased that Stephen is also an optimist these days. So thank you very much. Look forward to the discussion.
Now, we haven't planned this part exactly, but I know someone will want to start. I mean, I don't think there's anybody who's timid in this crowd here.
Well, let me just say, I wrote it down. I'll use it next week when I'm in Texas, pulling your goalie in the first period. I mean, that's such a powerful metaphor for Texans, you know, isn't it? But yeah, no, exactly. But I just want to just say here on what we just heard about responsiveness, because I'm woefully ignorant about the Canadian system these days, but I did do a retreat for the CEOs of the BC Medical Association and the equivalent across the country, and they had their retreat spring retreat not in Saskatchewan but in Palm Springs, and I think that's what which was very sensible in March. Anyway, so they were showing me this thing from BC, which is this cute little app where you could point on the knee and it would tell you what the waiting list for the knee replacement is, and I went, why wouldn't you just fix the waiting list? Why would you have to do an app? So I just completely agree that there are managerial innovations in large group practice that have been operating. I mean, Kaiser is same-day appointments. It's perfectly easy to do. It's a managerial task. And why we're not doing it is beyond me.
Okay. So that's an interesting point of departure, which is, to me, we always ask ourselves, why don't we scale and spread? So you look at the states where more or less 10% of the population gets the best combination of cost and quality and access in the world, I would argue. So then the question is, why doesn't everyone want to be like Kaiser? or Group Health or Geisinger or Mayo or all these clinics. They're right there. They're right next door. They're culturally identical, except for the rapists from Mexico. That's a Donald Trump. Come on. Right. So it occurs to me lately that, maybe there is some kind of natural limit to the distribution of qualities required among human beings to make these innovative systems work. As an example, the great systems, of course, get to pick who works there. When I did a site visit to Group Health in Seattle a few years ago, they get 17 doctors applying for every position that's open. They get 800 residency applications for 6 residency positions. So they weed out a whole bunch of people because they say you're kind of not culturally with the program, and you get to select people who have all of the attributes that we would love to have in our practitioners. They're collegial, they're open-minded, they're evidence-informed, but not everybody is. I mean, there's a natural distribution, a normal distribution of human attributes and talents and collegiality and personalities and play well in the sandbox, etc. So what if, the question is, that's all you're going to get? It's kind of, there's a limit. It's 10, maybe it's 20, maybe it's 25. Now, the counterfactual would be, yeah, but Sweden's pretty good everywhere. And then you look and you say, well, no, actually, Sweden isn't pretty good everywhere. Jönköping County, with 300,000 people, is fabulous. Stockholm, the biggest city, is the worst in everything on their comparative county indicators, the biggest and most urban. So it's just a question I've been posing to myself lately, which is, is this really a human selection process? And given the complexity of health and healthcare systems, does it take a better combination of attributes than we are likely to see in a generalized provider population to make all these things work? Which would be a pessimistic thing. And I'm not saying that I think this is true, but I'm wondering if it isn't possibly true and maybe accounts for the lack of spread.
And I think I just want to I looked hard to see where I could disagree with my fellow panelists, and it was difficult, but I was going to disagree, and I think it's positive with Stephen that you were saying it works well for most of the middle class. And I think it actually, as you went on to say regarding your mother, and Stephen's mother and my parents live in the same assisted living facility in Winnipeg, that I think it's not working. It's not working at all. And in fact, in the last year and a half, I mean, there are 2 examples I can think of where 2 members of the elite that I occasionally rubbed shoulders with both had developed serious neurological hard signs over the course of a week or 2 and were mutzed around for like a month until they ended up in emergency. And one of them was found to have a subdural hematoma, totally treatable. The other was found to have a grade 4 brain tumor. But in both cases, the fact that they were members of the elites did them no good. So I think actually that we really have a situation where I think we've got the gasoline vapor. We just need a spark. And the spark has to be a politician. Because we need to have effective politics to get things going. But I really feel that and the other thing I would say is that almost nobody I know knows any of what I just presented to you. They don't know that with existing resources, we should get immediate services. A couple of years ago, I had a private meeting with the retired CEO of one of Canada's largest financial services companies, and he was very interested in healthcare, wanted to do some good. So I went through this with him. It took him an hour and a half to understand this. Once he understood it, he said, well, we're just going to tell the doctors they have to do their work differently. And then before I could stop him, he was like, he had them drawn and quartered. I said, no, that's not the solution either. But what we need to do is we need to create the public dialogues, open dialogues, where the representatives of the medical associations are forced out of their dirty rooms You know, when you get out of that room negotiating with the BCMA, Steve, you probably feel like you need 18 showers to feel clean, right? And you just want to have that dialogue out in public. Like, once we get this stuff out in public, that's the spark that lights the gasoline, and then we can move forward.
A couple of comments, and again, as I say, I'm woefully ignorant about the Canadian situation, but it seems to me that one of the building blocks is this notion of large multi-specialty group practice. And, I've worked with Kaiser as an advisor for 30 years, and, they're not just an isolated phenomenon anymore. I mean, I had data in the packet, you'll see. We survey, I'm a great believer in Bob's thing, let's go find out. So we actually survey hospitals and how many of you have aspirations to be Kaiser-like. And it's now up around 8%, plus another 12% who are actively preparing to take risk, much in the way that Kaiser is. So I'm encouraged because we're seeing that phenomenon in the US context. But you cannot do it without the active engagement of clinicians. And they've got to be not just put upon and bullied into it, they've got to be leading this transformation. I'm going to be with a client of mine next week, Northwell, one of the large integrated systems in New York, and they probably employ now, I'm guessing, 5,000 doctors. We are seeing this sea change in American medicine where more and more physicians are part of organized integrated systems of care, and they're actively engaging in the re-engineering that Michael was talking about. One other point, Stephen's point, which I completely agree, and we actually survey doctors, and what we found is we created this segmentation, or it was actually my colleagues who actually know about statistics, it came out of the data, and we basically have what we call the blazing believers. These are the people that have drunk the Don Berwick Kool-Aid, is the way I would put it. They believe in integration. They're prepared to be in group practice. They believe in evidence-based medicine. They believe in using health IT. And they've gone from about a quarter of all American docs to about a third, right? At the other extreme, you've got what we call the independent resistors, who are, the caricature is cranky old surgeons from Texas, right? Who wish it was 1975 again without the disco, right? And they're going down in number, right? And it's partly a demographic phenomenon where younger, particularly female docs, are saying, I'm not signing up for 80-hour weeks of fee-for-service. I want a real life, And that transformation in medical care is going on. But I think Stephen's point is right. There is a normal distribution, even within these large integrated systems. And it frustrates the private purchasers to no end that they can't unlock those high-value, as Arnie Milstein calls it, top quadrant doctors inside these big systems. Because there are doctors who are much higher quality and much lower cost in terms of total cost of care, but you can't get at them without contracting with this entity. So I'm not pretending that we in the US have solved this problem, but I think in the Canadian context, given you've solved the single payer thing, these managerial initiatives should be encouraged and diffused. I'd be frustrated if I were sitting here.
Yeah, and just one thing about further to Michael's about so there is this people are not happy with the system. But remember, looking at Ian's and Norlu's distribution, I would say for 75% of the public, the health system is basically inconsequential at any predictable time. Most of us, if we're reasonably healthy, it doesn't matter. I know my primary care access situation is slightly ridiculous. And I know that if I needed something, and it's because of what I do for a living, right? But generally, what is the impact on my life? Zero. Pretty much zero. And when it is an impact in my life, it's too late for me to be an agitator because I'm sick. And I don't have time to be agitating. I want to get better. And then I'm going to be navigating the system. So that's also part of the democratic dilemma here, that it's vicarious care on behalf of someone else. It's not visceral. So, not facetiously, actually, or semi-facetiously, if you said the deputy minister and the minister of health have to be significantly disabled people, they have to have at least 3 chronic diseases to serve in those jobs, I guarantee you the system would change a hell of a lot faster than it does now because it's more personal. But back to, and I think this, again, why Ian, I agree with him in the frustrations. We say we can't do everything, but even a little thing. Advanced access scheduling's been around for, 20 years? Right. It's proven. It's been proven in Canada. Why hasn't one Canadian government negotiated with its medical association that 2 years from now, and we will give you all the tools and help you need, you don't get paid unless you have advanced access scheduling. It's pretty simple. It's easy. It's doable. None has done it. And then you get the statistics that Michael shows, that we lag the world in access to primary care. That one isn't even hard. That one isn't even risky. So if the question is, if we can't do that, why do you think we're going to do the better stuff? Why do you think we're going to make you all brilliant at looking after the frail elderly? And it is baffling about the lack of will, because honestly, it's not just, as Ian says, it's not just us and them. The clinicians, I'm sure, are frustrated too, right? I mean, they don't have a great day when some disgruntled patient comes in and says, why the hell did it take me 3 weeks to get an appointment here? So there's a whole lot of dysfunction that isn't just, well, we're really happy and you guys are miserable. I don't think anybody's happy. So the fact that even under those circumstances of probably universal disgust with the performance, we can't get the simplest thing done is quite remarkable. In fact, it's in a bizarre way one of our incredible achievements as a country.
Yeah, that and being the land of pilot projects. I should clarify, I'm not talking about bullying doctors at all. What I'm talking about is getting, as my good friend Rick Hudson would say, in dysfunctional families, nobody tells the truth. What do you hear in dysfunctional families? Don't mention the war when dad's in the room. So that's what we've got. And Dad, the abusive father, is our physicians collectively, not individually, but collectively. And they will not appear in forums and answer tough questions like this. I've only seen it twice in my life. 1982, Larry Grossman. How many remember Larry Grossman's initiatives? We don't know if it really would have worked because he was promoted to be treasurer, and so we don't know whether it would have worked. And then the 1992 Ontario Federal Provincial Territorial Meeting on Physicians, which followed up the Bear-Stoddart report. How many people were there in Ottawa in 92? And that's when we first saw the movement, when the Medical Association had to be out there answering tough questions. They were in complete disarray. They never had to do it before. And then they came back with, okay, we'll accept alternate payment as long as it's physician choice and it's net new money. Now, that was stupid, but we never had another conversation in the next 24 years. So in public dialogues, you end up with the last statement by one side is the de facto policy until you re-engage. So I think it's time for re-engagement. I'm not talking about bullying. I'm just talking about putting it out there and making it so obvious that the representatives of organized medicine will be too embarrassed not to say they're going to move. And I should say my own primary health care is really good. If my family doctor actually sees any of this, I want to say that she's wonderful and she gives me terrific access. But just to put that point, that it's not the medical associations or the colleges of physicians and surgeons that are the right institutions to implement clinical governance. It's going to have to be at a regional level, like in Scotland, it's going to have to be at a regional level, supported nationally. And I think that we can see Ontario's attempts to implement clinical governance has been totally clumsy. That they're showing political will in that the health minister is out there, criticizing his colleagues. But I don't think it's going to be any more effective this time than it was 4 years ago or 4 years before that. And as I challenged a deputy minister in Ontario 4 years ago, I don't do that much work in Ontario. As I challenged her then, I said, so you're going to these new negotiations in 2012. Have you looked at why things didn't go the way you wanted in 2008? And have you figured out a better strategy? No. So I think that until we get a politician who really knows how to do the politics, until we can get meetings like Larry Grossman and the federal health minister and Francis Lankin convened in '92, I don't think we're going to be making substantive progress.
Yeah. Just a couple of quick points to support my colleagues here. I love the vicarious versus visceral piece. We do surveys of consumers. I hate satisfaction surveys, right? I think they're a complete waste of time because Americans are nice people, right? They're satisfied with everything. Go survey the French if you want to see dissatisfaction. But so we came up with this emotional scale about healthcare, and the most negative is powerless, depressed, and angry. And then we have a big sample of 5,000 people, so we can cut it by people who actually use the system. Patients disproportionately feel powerless, depressed, and angry, to Stephen's point. And by the way, the distribution of those emotions look exactly the same when you survey doctors. So there is an issue here, and I would bet money it's the same on this side of the border.
With that, we get to open it up, and I know, Tom, you've been waiting there patiently, so we'll start with Tom and then over to the mic here, and if you could mention your name and where you're from, that would be great.
Hi, Tom Knows with the University of Calgary. In consideration of not just the emergence, but the degree of penetration now that we're seeing in the accountable care organizations, not only just in the U.S., but sometimes elsewhere, what do you think the policy and the practice implications are for Canada?
Well, I mean, let's be clear that, and again, I'm not a deep expert. I know Ted and some of his colleagues have looked at this stuff very closely, but the results are underwhelming from accountable care organizations, right? I mean, it's save a little, and I'm very close to Steve Shortell as one of the movers. I know Alec Fisher well. I mean, I think it's directionally correct, but what I will say is it has caused action in the conversation. I don't think CMS has got it quite right yet in terms of Medicare, but I work with the private payers, and there is the head of Anthem is a good friend of mine, Joe Swedish, and he's preaching to his people about total cost of care, about behavioral health, about consumer responsiveness, and true provider partnership. So there is a change in the conversation going on in the U.S. that I think is very constructive. Now, whether we can make it all work or not is another question. But I think it's exactly the conversation we're having up here, the lesson for Canada. You need to have constructive engagement with clinical leaders and change the way you pay for stuff